Greetings, Farm Dave here with one more discussion on behalf of Healthy But Whole in the perioperative management of electrolytes per element type. The first thing I want to summarize is why we care so much about electrolytes. Electrolytes are critical to the body's hemostasis, homeostasis, and everything else. From the most simple to the most critical biological processes, electrolytes play a role. If you think about cardiac channels, muscles, absorption of ions, everything is relying on electrolytes. An imbalance of these electrolytes may be created for infinite reasons. However, in a clinical setting, it is often due to fluid or blood loss, or fluid or blood gain, surgeries, medications, or the underlying disease states of the person. Surgeries. All major operations risk dysregulation of an individual's electrolyte hemostasis? I think I should say homeostasis. Looking at medications, there's thousands that can cause dysregulation of somebody's electrolytes. This includes, but is nowhere limited to, loop diuretics, ACEs and ARBs, laxatives, glucocorticoids, intraperitoneal chemotherapy, calcineurin inhibitors, succinylcholine. If you're never sure about does this medication cause this electrolyte to change, just look it up in Micromedics or whatever you prefer as a tertiary resource and see it under the monitoring parameters. Treatment. You always want to treat an electrolyte dysregulation prior to onset of symptoms. You want to target what they define as normal levels and or the middle range of normal, with specific levels, routes of administration, and care plans being very open-ended. Unlike other disease states, there's not just specific guidelines that you follow, target, etc. It is really per protocol, per labs that you gain, per products that you have. What you want to do is keep somebody in the normal or middle range of normal, and prevent symptoms from happening from electrolyte imbalances. The first electrolyte I'm going to talk about is potassium. So the main product choices that we have is potassium chloride, which is available as an oral, sublingual, or IV product, and others are in combination with other electrolytes. Technically, chloride is an electrolyte, but it's something you're much less likely to be grilled on rotation. Combinations such as K-phos and NutriPhos are summarized below. Dosing, and under all of my dosing, I include this star, which here at the bottom is just to reference that dosing recommendations are made for patients weighing at least 50 kg with normal renal function and without active loss in serum electrolyte. In those instances that I just mentioned, a patient may respond very differently. So for the dosing of K potassium, you would roughly expect 0.05 to 0.1 mg per deciliter or milliequivalents per liter per 10 milliequivalents that are supplemented. You can supplement potassium anywhere from 10 to 80, and then just factor it out per 10. You're going to expect somewhere between this range. So if you gave somebody 20, you're going to expect between 0.1 and 0.2, and you can do the math there. After 80, you can expect between 0.4 and 0.8 increase of that serum K. Per route, you're going to do a peripheral IV catheter with a maximum of 10 to 20 milliequivalents per hour. If you're doing a central venous catheter, you're going to have a maximum of 20 milliequivalents per hour or 40 milliequivalents per hour if they have continuous cardiac monitoring. This is because, as I referenced at the start, these electrolytes play a huge role in your cardiac functions, and going too fast is way more dangerous than being a little low. Adverse effects of potassium supplementation include nausea and vomiting, less or so diarrhea, abdominal pain, especially if somebody has a concurrent anticholinergic agent, because it slows down your gut motility. When it slows down your gut motility, it irritates the gut lining when the potassium is absorbing in high concentration. Also, those cardiac electrical abnormalities and considerations, which can really be fatal. If a patient presents with hyperkalemia, you can do enteral or rectal sodium polystyrene. There's many other agents, and if it's life-threatening, dialysis. Magnesium. It took me a while to understand why we are so hyperfixated on magnesium, but I was told that it is a limiting factor for all electrolyte supplementation, meaning if magnesium is low, you can't repair the other electrolytes which are dysregulated. The indication of magnesium goes beyond just using it to up somebody's electrolytes. It also has data showing that it's effective for post-op nausea and vomiting, post-op shivering, obviously the electrolyte dysregulation, and there is some studies looking at an adjuvant to analgesia for its anti-inflammatory effects in the form of mag sulfate. For me, magnesium is just the new vitamin D, where we're seeing it has good effects and we're slamming it on everything. I've seen a lot of psychiatrists recommend magnesium glycinate, and I even bought some because that's cool. The dosing for our normal healthy patients, we are only going to really give IV in an inpatient setting because PO has little to no absorption based on a poor bioavailability. For each 0.4 mg per deciliter that a patient is below the target goal, give 2 mags IV in 50 to 100 mLs over 30 to 60 minutes. If it is life-threatening, you can definitely go faster using 10 to 50 mLs over 2 to 15 minutes. Magnesium is often replaced just once a day. The products are mag sulfate, which is IV, or mag oxide, which is PO, much less likely to be used unless a patient is chronically taking that for magnesium supplementation. If you're correcting somebody's electrolytes, go with the sulfate. Adverse effects, you're most commonly going to see just the diarrhea. Phosphate. The dosing for phosphate is related similarly to the mag, so for each 0.4 mg per deciliter below normal, a patient should be given 15 millimolars IV, so 4 to 5 millimolars per hour with a maximum per hour of 7.5 millimolars, orally 3 times a day or 4 times a day. Dose adjustments, you want to note that an oral dose should be 3 times that of a parenteral dose, meaning that the parenteral dose, the one that goes into the IV, is going to be 3 times stronger than that goes in the mouth. If somebody has renal impairment, so creatinine clearance less than 30, they do require a dose reduction of roughly 50%. Dose conversions from an IV form, so IV sodium phosphate to PO potassium phosphate, is 15 to 16, just something to have in your tool belt when you're managing patients' electrolytes. Monitoring, you're going to do every 6 to 12 hours for severe hypophosphatemia and for those at risk of refeeding syndrome. Remember, refeeding syndrome is a higher risk for patients who are malnourished, anorexic, or suffering from alcohol use disorders. For all other patients, consider just checking their levels after 45 to 60 millimolars have been supplemented. The adverse effects of phosphate include nausea, vomiting, and diarrhea, and stomach pain. If somebody presents with hyperphosphatemia, there is phosphate binders. So this is your calcium acetate, your sevelamer, brand name Renvela, lanthanum, carbonate, Viltasa, or again, if it's life-threatening, it is something that's dialyzable. For calcium, I do want to note, which I haven't put on here, well actually we'll get down to there, but the dose, so for each 0.15 mg per deciliter below target on this ionized calcium, administer 1 gram of calcium gluconate per 50 mLs over 30 to 60 minutes, and you can repeat every 6 hours. The important part here is that this is not the calcium that you get back on a basic metabolic panel. You can calculate it using a corrected calcium, which is 40 minus the serum albumin times 0.02 plus the current calcium. You have to do that in practice because if you just try to treat based on a BMP, you have no idea what the impact of a patient's albumin is having on that reading. If they are severely hypocalcemic, so less than 75% of the normal, you may prefer calcium chloride as it has 3 times more elemental calcium than the gluconate form. Do note that if you're using calcium chloride, it must be given through a central vein, given the causticity to tissues. It will burn like crazy. If not causing serious structural damage to somebody's tissues, it will just hurt and suck. Monitoring. You want to monitor the serum calcium every 4 grams that are supplemented parenterally, and adverse effects include primarily nausea and constipation. So none of that nausea, vomiting, diarrhea, nausea, and constipation for the calcium. If a patient is hypercalcemic, you want to do sodium enteral or rectal sodium polystyrene, or if it's life-threatening, you can also dialyze it. Combinations of these electrolytes that I've mentioned throughout include sodium phosphate, potassium phosphate, which is available IV and PO, and Nutrifos. Looking at potassium phosphate, for each 15 millimolars of phos, it includes 22 milliequivalents of K. You can use this to, ratio out how much you're supplementing per ml, or the bags will usually tell you. It's very product specific and hospital specific. For the Nutrifos, you have 13 milliequivalents of sodium, 1.1 milliequivalents of potassium, and 8 millimolars of phosphorus. All of this information was obtained through the perioperative electrolyte management and up to date. And if you have any questions, I don't know how to answer them. Thank you. I love you. Good night.